the past week, our university community has a unique opportunity to engage with a series of highly inspiring lectures delivered by Professor Jayne, an internationally recognized expert, outstanding surgeon, researcher, and educator from the University of Leeds, and also from his colleagues Paddy Coughlin and Mikołaj Koval. These meetings has become much more than academic events. They have created an important platform for international exchange, professional dialogue, and the strengthening of cooperation between our institutions. We deeply value the openness, expertise, and willingness of the Professor Jayne to share not only the advanced scientific knowledge, but also his vision of the future of the modern medicine and medical education. Allow me to emphasize that this initiative is implemented with the support of the Fund of the President of Ukraine for Education, Science, and Sport. Such support is extremely important for Ukraine University today. It is enabling the development of international academic partnerships and integration into the global education and research community. For Bukovina State Medical University, this collaboration represents a meaningful step toward expanding international cooperation, promoting innovation in medical education, and strengthening our academic and research potential. Today's lecture dedicated to complications in colorectal surgery address one of the most challenging and important areas of modern surgical practice. Professor Jayne, on behalf of our entire university community, I would like to express our sincere gratitude for your valuable contribution to the academic life of our university, for your support of Ukrainian medical education, and for inspiration you have brought to our students, young colleagues, young doctors, and faculty members. We are also very much looking forward to welcoming you and Paddy Coughlin again to Bukovina State Medical University at the end of June. We truly hope that this is only the beginning of long-term and productive cooperation between our institutions, including future joint educational initiatives, research, collaboration, and international projects. Dear colleagues, dear students, I am confident that today's lecture will once again be insightful, inspiring, and professionally enriching for all participants. And I wish everyone a productive and engaging session.
Thank you very much, Mr. Director Igor. It's a very kind introduction. It's an absolute honor to give this last lecture in the series. We've had some great lectures. I've thoroughly enjoyed them. It's been great to see the engagement and the dialogue between our two institutions. So let me share my screen. There, how do I do this? Oh, I'm having trouble here. Sorry, for some reason I'm having trouble sharing my screen. Okay, let me try this here. Can you see my screen now?
Yes.
Yes.
You can. Okay,
Yes.
let me put it into presentation mode. Can you see that?
Yes, everything is okay.
Okay, that's great. Unfortunately, now I've shared my screen, I can't see you. So you'll have to shout if you want to stop me or ask any questions. So today I'm going to talk about what is probably the most difficult and feared complication of colorectal surgery, and that's the problem of anastomotic leak. So sadly, we'll all be familiar with this complication. We do a bowel resection for whatever reason, be that benign or malignant disease, and then we join the two ends of the bowel together. And it doesn't matter how we do that, whether it's hand sewn or stapled, there's various techniques. It looks perfect at the end. We're happy with it. We close the patient's abdomen up. And then 3 to 5 days later, the patient becomes unwell. There's clearly a problem. We end up usually taking them back to theatre, and we find that the anastomosis is falling apart. And then we're in a situation of trying to control the damage and the sepsis. It's obviously a condition that's associated with high morbidity. There's also a mortality risk. So around 20–25% of patients who suffer a leak won't survive. For those people who do survive, it's a very long journey. So it often involves very expensive stays, long stays on intensive care, and then a slow rehabilitation, not just in hospital, but for months afterwards. And it's not just the leak. Very often there are ramifications of that leak. So there may be wound problems, dehiscence, permanent stomas, incisional hernias. So it can have lifelong effects. And it doesn't matter how we do the operation, whether we do it by open surgery, whether we do it by laparoscopic surgery, or even if we do robotic surgery, the leak rate stays the same. And it hasn't changed over decades. It doesn't matter what we do to try and improve our surgery, try to improve our perioperative care. We have this leak rate, which is stubborn. It refuses to change. And this, I just picked one study here just to illustrate this. This is a big laparoscopic versus open study a few years ago called the COLORECTAL 2, a big European trial. And you can see that laparoscopic or open surgery, the anastomotic leak rates are the same. It's also very expensive. I talked a little bit about the consequences for the patient, which are probably the most important, but there are consequences for hospitals and the efficient management of care pathways. Again, this data is a little bit old. There isn't anything really very up to date about the cost of an anastomotic leak, but you can see that patients having an operation who don't leak compared to those who do leak, it increases the cost of care by about 3 times. And that depends on the severity of the leak. So if it's a reasonably small leak and it can be managed conservatively, then the costs can be kept under control. But if you end up taking the patient back to theatre and doing remedial surgery with stomas, then the costs escalate. There are also consequences for disease biology. If a leak occurs when the operation is being performed for cancer. So this study is a large meta-analysis of 21 studies over 21,000 patients. And you can see when there's a leak occurs in the presence of a cancer operation, it doubles your chance of developing local recurrence. And similarly, it almost doubles your risk of dying from cancer. I'm sorry, every Thursday this happened. It happened last week. We have our fire alarm system. Now, an anastomotic leak, can you modify it? Can you try and reduce the risk? There are some things you can do. There are certain modifiable factors these are usually patient factors. So getting the patient as fit as possible for operation, and there are various strategies, prehabilitation strategies to try and achieve that. But there are other factors that are not modifiable, this slide shows rectal cancers. So male sex, a narrower pelvis increases the risk of leak. We know that the risk of leak increases as you go down the rectum towards the anus. So the lower the anastomosis, the higher the leak rate. And also some of those adjuvant treatments we try to give to contain the tumor, the radiotherapy, these can also increase the risk of leak. One exciting technology that emerged around a decade ago now was the use of indocyanine green and near-infrared imaging. Indocyanine green, ICG, has been used for many years in different specialties such as cardiology, liver imaging, and it's good at looking at the blood supply to organs. So it's very simple to use. You mix it up with water for injection. You give it by an intravenous bolus, and it's retained in the blood stream. And if you shine a light of suitable wavelength, then it excites a fluorescence. And the beauty about ICG, you can see in this graph in the bottom right, it's in what they call the first biological window. So it's between the natural fluorescence of deoxyhemoglobin and water. So you can get a really intense fluorescence with ICG because there is no interference from other naturally occurring fluorophores. It's very easy to use, as I said. It is very safe. It binds almost exclusively 90% to plasma proteins in the blood, and that's why it's retained in the vascular compartment, and that's why it's a good drug for angiography. It's excreted in the liver and the bile within 5 minutes, so rapid clearance, which again is very useful for using it to assess perfusion. So this video shows how we might use it. This is a left hemicolectomy. We've mobilized the left colon laparoscopically. We give the ICG and we can see the blood, the perfusion in green, and we can tell which parts of the bowel are well perfused and which aren't, and that helps us decide where to transect the bowel and where to do our anastomosis in an area of optimal blood supply. And there is growing evidence that ICG, by optimizing the blood flow at the anastomosis, can help reduce anastomotic leak. The first indication that ICG might be helpful came from the Pillar 2 study. This was a multi-center study in the US. It wasn't randomized. It was an observational cohort study, and it contained a mixed cohort of patients, so benign and malignant disease. But what was remarkable about this study is that it reported a clinical anastomotic leak rate of 1.4%. Now, that was totally unheard of. We were used to anastomotic leak rates in left-sided bowel resections of around 10%. So 1.4 was really quite extraordinary. And we felt we had to test this rigorously. And to do that, we performed a randomized controlled trial. This was funded by the UK government, the research arm called NIHR. And it was a very simple study design. So it was a 2-arm study comparing standard white light laparoscopy versus laparoscopy with ICG or fluorescent angiography. So patients with rectal cancer, and they were all rectal cancer patients, and the reason for that is because rectal cancer has the highest risk of anastomotic leak. So it was the most important group for us to study. So patients with rectal cancer randomized 1-to-1 either to white light laparoscopy or ICG. They had their surgery, they were followed up for 4 weeks, various quality of life, health, economic, as well as clinical assessments. Importantly, at 4 to 6 weeks, all patients had a contrast enema. And the reason for that was to look for subclinical leaks, because subclinical leaks can actually have quite a profound impact on patient function. And then the final follow-up was at 90 days. It had to be a European study because at that time, the use of ICG was fairly limited. It wasn't routine by any means in the UK. So there were about 25 sites across Europe that contributed. The primary endpoint was the clinical anastomotic leak rate at 90 days. Now, we assess anastomotic leak by 3 grades. So grade A is a small leak. It doesn't need any therapeutic intervention. It might need some antibiotics, but generally it will settle. Grade B does need some sort of therapeutic intervention, but it doesn't need the patient being taken back to theatre. So it might be endoscopic treatment, or it might be percutaneous drainage with antibiotics. Grade C is the most severe leak, and that's the leak that patients need to be taken back to theatre. And quite often that results in the anastomosis being taken down and a stoma being made. So this clinical anastomotic leak equates to the grade B and grade C leaks, not the grade A. The secondary endpoint for the study was all anastomotic leaks. So that was grade A, B, and C. Secondary endpoints we were interested in, if ICG did reduce anastomotic leak, why might that be? Was it changing the way the operation was done, how the anastomosis was made? We were interested in all post-operative complications, the length of hospital stay, the need for reinterventions, and there were also functional outcomes, because if you have a leak in the pelvis, it can affect your rectal function or your neorectal function if you manage to salvage the anastomosis. So we were interested in low anterior resection syndrome, quality of life, and also the cost of a leak, the health resource utilization. So to be eligible to take part in the study, there were site-specific eligibility. So you obviously had to be a site that was experienced in doing rectal cancer surgery. You had to have prior experience in ICG, near-infrared angiography, and you had to be able to recruit a reasonable volume of patients, so at least 1 a month, 12 a year. And for patients, they had to have a rectal cancer. It was all rectal cancers, cancers of the low, mid, upper rectum, and it had to be elective surgery, but it could be either laparoscopic or it could be robotic. It couldn't be open surgery because the near-infrared hardware that we were using was laparoscopic. So the hypothesis was that with the use of ICG, we could reduce the rate of a clinical anastomotic leak. That's our primary endpoint. We could reduce that from 12%, which is the accepted leak rate for rectal cancer surgery, and we could halve it. We could take it down to 6%. To be able to prove that, we needed to recruit 880 patients. And to do that, we needed around 25 centers throughout the UK and Europe. We included in the study design a planned interim analysis, and that was scheduled at 554 patients. And when we got to that 554 patients, we had an independent data monitoring committee scrutinize the results. We as investigators were blind to that. And the independent committee came back to us and said, look, we don't think you need to go to 880 patients. There's no need to do that. We suggest you reduce the sample size to 766 patients. So that is what we did, and we recruited 766 patients in total. So these are the results. So the middle column, the surgery minus IFA, that's the normal white light laparoscopy. On the right-hand side is the ICG, the fluorescent angiography group. So that's our intervention group. And these are the baseline characteristics. So it just shows that this is a normal cohort of patients who would ordinarily undergo rectal cancer surgery. The patients weren't being specifically selected for the study. It wasn't all the easy patients going into the study. So we can see that there were more males than females in both groups, and that correlates with the fact that rectal cancer tends to be more prevalent in males. Quite a lot of our patients undergo neoadjuvant therapy. That's sort of standard treatment for locally advanced rectal cancer in the UK. The majority of cancers were T3 and T4, so locally advanced, and a lot of them were below the peritoneal reflection. So the more difficult tumors were being put into the study as well. At that time, around a third of patients were being done robotically, the rest laparoscopically. If we repeated that today, it might be closer to 40 to 50% being done robotically. And the conversion rates were similar in each group, around 8%. So the primary endpoint, clinical anastomotic leak, we saw a reduction in the leak rate from 15.2% with white light laparoscopy down to 10.5% with ICG. And if we look at those groups B and C, those are the groups that form the clinical anastomotic leak, we don't see any difference in the grade C, but the difference is in the grade B, which reduces from 8.7 to 3.2. If we put that into our statistical model, although we see this reduction from 15.2 to 10.5, it doesn't quite reach statistical significance. So we cannot say conclusively that ICG reduces anastomotic leak in rectal cancer, clinical anastomotic leak in rectal cancer. Of the other factors, we see that the use of short course radiotherapy with no delay, that's highly significant for increasing your risk of leak, but we have to be very careful here because the numbers are really quite small. And the other factors, we know that tumors below the peritoneal reflection tend to have a higher leak rate, and that is confirmed in our results as well. If we look at the secondary endpoint, all anastomotic leaks, so that's grade A, B, and C, we see an even bigger effect. So a huge 20.8% leak rate with white light laparoscopy alone, and that almost halves to 13.7% when we use ICG. And we see the same trends if we look at it by different grades. So no difference in the more severe leaks. the difference here is being driven in the A's and B's. So they are reduced by about half with the use of ICG. And if we put that again into our statistical modeling, we see this reduction from 20.8 to 13.7. This time is highly statistically significant. We've seen the same trends. We see that the leak rate is significantly higher in males. We see that short course radiotherapy again is associated with a greater leak rate, and the more difficult tumors below the peritoneal reflection, again, significantly more leaks in that group. When we look at our two groups to try and see why there might be a difference, we see that surgery was changed when ICG was used more often than when white light laparoscopy was used. So with ICG, the surgeon changed the anastomotic plan in around 12.5% as compared to 7% when white light alone was used. And that difference was really seen in the change in the proximal transection level. So when the surgeon gave ICG and assessed the blood supply with fluorescent light, they changed the planned site of level of transection and anastomosis in 6.7% and only 3% when they used white light alone. And it was the proximal transection level that changed rather than the distal level, the rectal stump. So we can see that ICG is having an effect on surgical decision-making. As expected, with a reduced leak rate with ICG, we see that the overall complication rate at 90 days is lower. It's still high because complications are unfortunately common in this sort of complex big surgery, but it's reduced with the use of ICG. And similarly, the reintervention rate at 90 days is lower with ICG, presumably because the leak rate, again, is lower. I've talked about ICG and the requirement to have an optimum blood supply, tissue perfusion, to ensure that an anastomosis heals. But even when we have optimal tissue perfusion with ICG, we see that the leak rates are still around 10%. So we can halve the overall anastomotic leak rate, but we can't make it go away. And that suggests that there are other factors at play. It is not just about the blood supply. And one of the other things we've been investigating is the possible role of the microbiome in anastomotic leak. Now, there's been an increasing amount of work in this area and interest in it, really driven by a professor of surgery, John Alverdi in Chicago. And the hypothesis is that during a bowel resection, you traumatize the area. Naturally, you're performing surgery, and then you join the two ends of the bowel together, and there is associated upregulation of various cytokines and inflammatory mediators. And this and the tissue trauma environment changes the way that the microbiome in the gut behaves. So it becomes more virulent. It responds to this healing environment. And the bacteria become more virulent. They upregulate various adhesion factors. They start producing collagenase. And it's this uncontrolled collagenase production by certain bacteria that is believed to swing the balance of anastomotic healing more towards non-healing or dehiscence. So we were interested in this, and if you look at the literature, it goes back, this is 30 years ago, these studies were being done. And there's some nice studies. This was done in Cardiff at the Welsh National School of Medicine, and they looked at anastomotic healing in a rabbit model. And what they did is they had two groups. One, they gave just saline as control, and the other group, they gave a protein. Now, a protein is a collagenase inhibitor. So the hypothesis was by inhibiting the collagenase production, they should see less anastomotic leak. And that proved to be the case. So in the protein group, you see that actually the burst pressures and the breaking strength and the amount of collagen within the tissues is much higher than in the saline group. And they went on to actually look at this in patients, and they took 100 patients undergoing segmental colectomy. Half of them received the protein, the anti-collagenase drug, and the other a placebo, and they saw a reduced leak rate when they inhibited the collagenase production, and also radiological leak rate. So there seems to be human evidence supporting quite a lot of animal experimentation. And we see other corroborative evidence in a lot of studies that are now being completed looking at the role of mechanical bowel preparation with or without antibiotics in complications, including anastomotic leak. So I've picked one out for as an example, but I could have picked 3 or 4 which all show similar things. So in this large study of 8,000 patients from a national US database, you see the anastomotic leak rate was 4.6%. If you gave mechanical bowel preparation, it dropped to 3.5. If you added in antibiotics, it reduced further to 2.1. So it seems as though that microbial load and its composition does influence the rate of anastomotic leak. So we were interested in this, and we took the opportunity, being as we were performing a big randomized controlled trial of leak, to embed a microbiome study. So within our INTACT trial, all the UK patients, and it had to be UK because we were collecting samples, we asked all UK sites to send us rectal swabs at 3 time points. One before the operation, secondly at the time of the operation, and thirdly post-operative, so between 3 and 5 days post-operative. We collected these fecal samples and we subjected them to 16S RNA sequencing. That's to identify the individual species of bacteria present. And then we also cultured the bacteria and looked at their ability to produce collagenase. And what we saw was a huge variation in the microbiome. And the biggest variation was actually between patients. So one patient to the other patient, we saw huge variability in the microbiome makeup. We also, I haven't put it in this slide, we also saw a lot of variation between different regions and different hospitals in the UK. So around 66% of this bacterial diversity was accounted for on the per patient basis. When we looked at our samples from our 3 time points, they're shown here in this scatter plot. The baseline sample is in orange, the intraoperative is in green, and the postoperative is in blue. And we see that the baseline and the intraoperative begin to sort of diverge between those time points. And then the postoperative are tending to form a separate cluster. So there's a divergence in the biodiversity. And we begin to see different species of bacteria emerge. So between baseline and post-operative, in green, we see Pseudomonas becoming more predominant. We see Streptococcus becoming more predominant in the post-operative, and also Enterococcus here in orange. So the microbiome is changing during this patient journey. And that's represented here in this plot. So what we see is at baseline, we start off with a microbiome in the gut, which is really quite diverse. And then as we go, the patient has their bowel prep, and then they have intraoperative antibiotics. And these interventions, what we see is that the biodiversity shrinks, but certain species begin to predominate and emerge. And when we cultured these fecal samples, we see that there's a small but definite increase between the preoperative and postoperative collagenase producers within these samples. So the species that are present postoperatively seem capable of producing more collagenase. And importantly, you'll recall from the previous slide that I said that Pseudomonas and Enterococcus began to flourish in the postoperative period. These were the species that were more commonly the collagenase producers. So we've directed our efforts at trying to think of novel ways to counteract this potentially deleterious effect of the microbiome and the collagenase effect that we've seen in the postoperative period. And one of the ways we've tried to do this is by using amental-derived regenerative cells. So these are cells within the amentum that are actually, they're stromovascular cells that are important in various aspects of wound healing. So whether that's cell differentiation, immune modulation, angiogenesis, they play an important role in healing and repair. And what we thought would be interesting is at the start of an operation, we could harvest the amentum. There's lots of it, easy to harvest. We could extract the regenerative cells from the amentum, suspend them in a gel formulation, and we could do that all within 2 hours. So by the time we've done the anastomosis, we've got a gel with cells in it back that we could actually put around the anastomosis. And this would hold these regenerative cells around the anastomosis and hopefully promote wound healing. So to test this, we developed a mouse model of anastomotic leak. We spent quite a bit of time perfecting the model. We needed a model with a high leak rate of around 50% so that we didn't need huge numbers of animals in our experiments. So we would extract the amentum. The amentum in a mouse is very flimsy, but we would extract the cells from the amentum. We would make the anastomosis, and then we would put the cells with the gel around the anastomosis. And what we found is that the overall leak rate was just under 50%. This is how we designed the anastomosis, so we'd expected it to have a high leak rate. The leak rate was reduced when we put cells and gel around the anastomosis. So it went down to 46% as compared to 51% in the control group. So only a small reduction, but nevertheless, potentially a signal of efficacy. But it didn't get anywhere near statistical significance. And that was because of the numbers that we were able to do. But the interesting thing was when we looked, we had a further control group. We had one group that just had an anastomosis. We had another group that just had the gel. That was our gel control. And we had the third group, which had the gel and cells. And if we looked at any group that had the gel around it, then we saw that if you had gel around your anastomosis, you tended to form an abscess. So most of those animals that leaked formed an anastomosis, and only 15.2% had diffuse fecal peritonitis. Whereas if you had no gel around the anastomosis, it was almost completely the mirror image. Few of those animals formed localized abscesses, and most of them went on to form fecal peritonitis. So we thought that was really interesting. At the same time, we started working with a company called Advanced Medical Solutions, and they were actually using the same gel or sealant that we'd been using. It was an alginate sealant, so it's made from seaweed, and in one of these columns of the syringe you have the alginate, and in the other you have the chelating agent, which is a calcium solution, which makes the alginate solution gel. And we thought this would be really interesting to have a look at this in a clinical study. And we were particularly interested because the solution or gel was made from alginate. Now, alginate from seaweed actually has a very high iodine content, and there's reasonable evidence that it has an antimicrobial effect. So we thought that was really quite interesting, putting something around an anastomosis where we know that the microbiome is probably having an effect, and you're not just putting a sealant around, you're potentially putting something that's going to alter the microbiome as well. So we performed a clinical study. This is just a short video. It shows that the solution is very easy to apply to an anastomosis. The study was an international study, 8 international sites, 27 surgeons, recruited 160 elective colorectal cancer cases, and we saw a very low anastomotic leak rate, so only 3.1%. Only 0.6% of patients needed to go back for a reoperation, and it was easy to use with very low morbidity. So that has been a very interesting study for us, and it has led to us being funded now for another larger randomized controlled trial that will be done, funded by our UK government, to look at this study in a rigorous randomized manner. So that's something that we will be starting over the next 6 months. As well as alginates and sealants, one of the other things we've been investigating, and I have a PhD student studying this at the moment, is the use of tranexamic acid. Now, people will be familiar with the use of tranexamic acid as an agent used to stop bleeding, mainly following trauma, or actually increasingly used now in major elective surgery. But as well as its effects on reducing bleeding, interestingly, tranexamic acid can also interfere with how bacteria behave. So it inhibits the way the bacteria interact with the fibrinolytic pathway, and it reduces the ability of bacteria to produce collagenase. So we thought that was really interesting. If we treated the bowel with tranexamic acid, it may actually stop this upregulation of collagenase that we see from the microbiome. And in rectal cancer surgery, it would be very easy to do. So at the end of surgery, you just place a catheter through the anus at the site of the anastomosis, and then you can deliver the tranexamic acid as a simple enema solution. So this study is ongoing at the moment. It is only a feasibility study. It aims to recruit 40 patients. I think we're at 36 patients now, so we've almost finished it. So all our patients undergoing rectal cancer resection have a catheter. Half of them get the tranexamic acid, the other half just get a saline placebo. And then we take samples of the rectal microbiome at 3 time points to look at changes in the microbiome and collagenase production over this time. So we hope to report on this within the next 6 to 12 months. So in summary, anastomotic leak continues to be one of our biggest and most feared complications in colorectal surgery. I think the use of ICG has changed the way we think about anastomosis, and it has helped us optimize the blood supply and reduce the rate of anastomotic leak. Its effect seems to be in preventing the lesser degree of leaks, the grade A and grade Bs. I think if an anastomosis is going to completely fall apart, it's going to be a grade C, there is probably another reason for that happening rather than the blood supply. But even with ICG and ensuring optimal perfusion to the anastomosis, we were only able to reduce the leak rate by about a half. So we need to be thinking about the other factors at play here. And I think the evidence is emerging that the microbiome does have a causal role to play in anastomotic leak. I think there's a lot more work to be done to understand that better. But if we do understand how the microbiome can interrupt bowel healing through its produce of various collagenases and metalloproteinases, then we can start thinking about strategies to mitigate that. And that might include some of the antibacterial effects that we've seen with the alginate sealants. It might include things like tranexamic acid that we're currently exploring. So thank you very much for listening.
Dear Professor Jayne, thank you very much for this amazing, inspiring, and practically oriented lecture. Now we open a very short session of questions and answers. If you have, please raise your hand, or please our colleagues maybe from our lecture hall, do you have the questions?
Yes, thank you very much for your interesting lecture. We have a few questions.
Hello, Professor Jayne. Thank you for interesting lecture about this interesting topic. If I can ask you, am I correct to say that there is no one solution to this problem? And so, like you showed us, that different methods give like 4%, 5% of lessening risks and damages to the patients. And maybe in the future, we will add new technology, as you showed about antimicrobial gel as a sealant, and maybe using the hemostatic agents. And finally, we just will wear down the problem step by step until I think like in 5 or 10 years, we will have new guidelines about the surgical health with this condition, and we'll be living in more healthy world.
So I think that's right. I think we have to accept that, you know, there are several factors at play. The blood supply is obviously important, but there are other aspects of surgical technique, etc., which are important. So I think we need to be thinking about what is the optimal package. What are all the different aspects that we have to think of if we can try and reduce that leak rate down towards 0? So I think we have a much better understanding about the blood supply now because of ICG. What we have to do is start tackling all those other factors that are also at play that perhaps we don't really understand that well at the moment.
Yeah, thank you very much. Thank you.
Yeah.
Thank you
Thank you
very
once
much.
again. We have no further questions. Thank you.
Thank you very much. Dear Professor Jayne, on behalf of the project coordinator, I would like to express the deepest gratitude to you and your colleagues, Patrick Coughlin and Nikolai Koval, the administration of Bukovinian State Medical University by represented the rector of our university, Igor Geros, and vice rector, Professor Oksana Godavanets, and also our big team, our colleagues who helped and support to implement this project. There are Associate Professor Ruslan Knut, Associate Professor Igor Simyanev, Associate Professor Anastasia Katalban, Assistant Professor Tetiana Antofichuk, Head of the Department of Technical Training at Alexander Melnichuk, Press Secretary Oksana Vivsyanek, and all students, young researchers, professors who had interest and time to join our online meeting. Thank you, everyone. Wish all the best and waiting for visit of Professor Jayne and David Jayne and Patrick Coughlin in the end of June. Welcome to Chernivtsi. Welcome to Bukovinian State Medical University.
Thank you very much. We're very much looking forward to our visit. So that's going to be really special. Thank you.
Thank you.
Thank you. We wait you.
Ми можемо
Bye.
завершувати наш запис. Всім дякуємо.
Goodbye.
Bye-bye.
Бай-бай.